Hi everyone, this is Ollie, one of the Clinical Teaching Fellows, and welcome to this presentation on hyponatremia. This presentation should only be about 15 minutes or so as a brief introduction to hyponatremia. It's quite an important one, I think, to understand because it's definitely one of the most common electrolyte imbalances that you'll come across in your working life, affecting up to about a third of hospital inpatients. Just to recap, a normal sodium level should be between about 135 and 145. Anything less than 135 is classed as hyponatremia. Moderate hyponatremia less than about 130, and severe hyponatremia as less than 120. Although it is important to acknowledge that not only the actual value of the sodium level is important, but also the rate at which it develops. So a hyponatremia which develops very rapidly will often present with more severe symptoms, which develops slowly. And hyponatremia, essentially it can develop because of one of two things. It can either be to changes in the sodium metabolism, so conditions which affect the rate at which sodium is retained or excreted, but it can also be due to changes in the overall fluid volume status. Clearly, if we're retaining more water overall, that will dilute the sodium that we have, causing a hyponatremia. And we'll look at examples of both of these as the presentation goes on. Probably the most important thing to cover is how to assess someone with hyponatremia. The history will clearly be important. We'll come on to some of the signs which we see, although they're often quite general. The clinical examination is important, particularly focusing on neurological signs, but probably the most important part of the assessment overall will be looking at the fluid volume status, because this will affect how we manage the hyponatremia. After this, it's important to look through the drug chart, as there are often medications like diuretics and things which can cause a hyponatremia, so it's important to review these. And we should also have a look at some of the investigations which we use to determine the exact cause of the hyponatremia. So the history, really we're looking for neurological symptoms. I mean, hyponatremia in general presents with quite vague symptoms, things like loss of appetite, a bit of nausea, just generally not feeling very well. But as the hyponatremia becomes more severe, we'll start to see more obvious neurological signs like headache, confusion, and then eventually seizures and reduced consciousness. We'll then skip forward a little bit to look at investigations. A VBG or an ABG can be quite helpful in giving us a sodium result very quickly, and this is particularly helpful when we're monitoring someone that we're treating for hyponatremia, which we'll look at in the last slide. Userney is clearly at the centre of investigation for this to get an idea of the sodium level overall. And then the general investigations which I would do for anyone presenting with a hyponatremia would include a paired urinary and serum osmolality, and this will help when we look more at the fluid volume status, as well as a urinary sodium. And practically, it's important to make sure that you send all of these results off at the same time, because the lab will need the usernees, the urinary and serum osmolalities, and urinary sodium all at the same time to compare and generate a meaningful result. When we look at some of the other endocrine causes of hyponatremia, we'll look at the role of liver function tests, thyroid function, and a 9 AM cortisol level as well. So the most important assessment to do really is your fluid volume status, and if you're not already familiar with how to judge a patient's fluid status, that's probably something which is worth recapping at this stage. I've classed hyponatremias into three different categories based on the fluid status: hypovolemic, euvolemic, and hypervolemic, or fluid overloaded. We'll start by taking a look at hypovolemic. So there are two possible causes of a hypovolemic hyponatremia. The first is that both sodium and water are being lost from the kidneys. For example, diuretic drugs are the most common cause of this. So you'll end up drying the patient out and they will lose lots of sodium through the urine. But other causes might also be renal failure and Addison's disease. The other place that we can lose sodium and water are anywhere other than the kidneys. So this makes up the second group of causes. Here I'm thinking about things such as diarrhea, vomiting, burns, trauma, things like that where we can potentially lose a lot of fluid and electrolyte from a system other than via the kidneys. Really, the urinary sodium will be the test which helps us distinguish between the above causes, clearly telling us whether the sodium is being lost from the kidneys or from somewhere else. A raised urinary sodium suggests increased renal losses, like in renal failure, but a normal urinary sodium suggests extra renal losses, like in diarrhea or vomiting. Again, clearly the history will be central actually in telling you where the likely source of fluid and electrolyte loss is. So touching on the value of the history, on examination we would expect to see signs of hypovolemia such as tachycardia and hypotension, reduced skin turgor, postural blood pressure drop, for example. Management, really, if there are any drugs which might be either causing or potentiating the effect of the hyponatremia, such as diuretics, we should stop or pause them. And then we just need to replace the lost fluid, usually with normal saline. The next cause which I'm going to look at, I'm going to skip euvolemia and come to that next. We're going to look at hypervolemic hyponatremia, so hyponatremia in a fluid overloaded state. And the most common causes of a fluid overloaded state would be heart failure, kidney failure, and liver failure. The history, they may have a past medical history of any of the above, and they may also present with limb swelling. On examination, you'll probably find peripheral edema, a raised jugular venous pressure, bibasal crackles, and possibly ascites, especially in the context of liver failure. The management is very straightforward. First, we should restrict fluid intake. So usually we restrict to about a litre and a half of fluid, and it may be necessary to diurese the patient as well with something like furosemide. This may seem a little bit counterintuitive because on the previous slide we said that diuretics can actually cause electrolyte loss as well as fluid loss. But in this context, a lot of what's driving the low sodium is actually because it's being diluted by loads of water. And whilst diuretics cause you to lose both fluid and water, you will lose proportionally more fluid than you do electrolyte. So actually getting rid of a lot of that excess fluid will help to normalize the sodium, even though we will be slightly increasing renal sodium loss. We'll now talk about euvolemic hyponatremia. And the main condition which we talk about in this context is syndrome of inappropriate ADH secretion, or SIADH. But there are other causes as well, albeit reasonably uncommon, things like severe hypothyroidism and glucocorticoid deficiency. Which is why, in addition to the usual investigations for hyponatremia, it's important to do a 9 AM cortisol and thyroid function tests when you notice a hyponatremia in a euvolemic patient. We'll look a little bit more at SIADH. Hopefully you'll be a little bit familiar with this already. In essence, we're talking about a condition where excessive ADH release leads to a dilutional hyponatremia because of excessive water retention in the kidneys. You should be able to remember that ADH is secreted by the posterior pituitary, and it binds these V2 receptors in the kidneys, and that binding leads to increased expression of aquaporin receptors in the collecting ducts, and this leads to increased water retention. And there are many different causes of SIADH. Some of the ones to be aware of, though, include certain drugs, including SSRIs and some antiepileptics. Lung cancer, this is a known paraneoplastic effect of certain cancers, especially lung cancer. And also in brain trauma, we sometimes see this. When we send off that normal panel of investigations, we should expect to see diluted blood, and concentrated urine. because remember, all of that water that should be passed into the urinary stream is actually being reabsorbed. The resultant urine is very concentrated because not much water is being passed on, but the blood is much more dilute than we would expect. As such, we will see a low plasma osmolality and a raised urinary osmolality. If the cause isn't known, then we should also prompt us to do some investigations to look at the likely cause of the SIADH. Given that lung cancer and CNS trauma are both reasonably common causes, as well as drugs, we should obviously review the drug chart, but also consider doing a chest X-ray and a CT head. Management, well, review those commonly offending medications. Fluid restrict, as in hypervolemia, to 1 litre or 1.5 litres a day. In cases where the hyponatremia persists after a couple of days in spite of fluid restriction, then endocrinologists may advise using a V2 antagonist, which will directly antagonize the binding of the ADH at the V2 receptors. These are Vaptan drugs, things like tolvaptan. But again, this isn't something that you'll be initiating yourself. It's likely something which will be coming from an endocrinologist. So any of these can cause a severe hyponatremia, which I think is worth discussing in a little bit more detail. Really, we're looking at a sodium of less than 120, or the presence of any neurological symptoms like seizure, reduced conscious level, headaches, things like that. These patients really need to be admitted to ITU because they can become very unwell quite quickly. We then need to bring the sodium level up with some saline. This may be normal 0.9% saline, but in ITU there's also the option to give hypertonic saline, which is 3%, to bring the sodium up a little bit more quickly. There is something important to bear in mind whenever we are correcting sodium levels, and that is that we can't correct them too quickly. It is crucial not to exceed a rate of correction more than 12 points per day, because correcting the sodium too quickly will cause quite significant shifts in water and electrolytes in the body, and especially within the brain, and it can actually draw water out of the brain, leading to a potentially fatal condition called central pontine myelinolysis. So it's important to correct the sodium at a reasonably slow and steady rate. And that's the increased monitoring afforded in the ITU setting is why these patients will often end up there. This leads us on to talk very briefly on this last slide about the monitoring of hyponatremia. And the frequency with which we have to monitor the sodium level really depends on the severity of the hyponatremia. So in severe hyponatremia, we really need to be checking with a VBG at least every 2 to 4 hours, just to make sure that we're not bringing it up too quickly. In moderate, probably twice a day, so once at the start of the day, once at the end. And in mild, usually once a day is sufficient. And actually some patients, for various reasons, may not actually get back up to above 135, but often people will tolerate a sodium of somewhere between 125 and 135. In addition to monitoring the sodium level, it's important to assess daily and document in the notes the fluid input and output status, a fluid status exam on the patient, their postural blood pressure, as well as any reported symptoms. I hope that was useful. It's a very brief introduction to hyponatremia. We're more than happy to answer any questions. Either grab one of us in person or send us an email. And I would suggest going back over and looking at how to conduct a fluid exam if you're not already familiar. All right, thanks guys.